Well, hello once again, everybody. My name is Hua, lecturer of anatomy, physiology, and medical terminology. And today we'll be continuing our excursion into the abdomen by talking about the groin and inguinal canal. This is a region that is very important in terms of clinical setting because of the fact that there's so many things that could happen here in terms of clinical pathology conditions. And therefore, you need to get it right. All right. So let's define the groin or the inguinal region one more time. It is the area of junction or connection between the anterior abdominal wall and the thigh. Now, if you look at the anterior abdominal wall like this, there is going to be a point right here where you would have the inguinal ligament. Okay. And after the linguinal ligament, or I should say inferior to the inguinal ligament, more distal to the inguinal ligament, whatever, you will be able to see that the anterior abdominal wall has changed down here to become the lower limb. All right. And therefore, this area right there on both sides are going to be the inguinal regions on both sides. Okay. So now this region is an area that is weakened from changes that occur during development. And therefore, structure within the peritoneal cavity, like for example, intestinal loops, can protrude through this area, creating what is known as an inguinal hernia. An inguinal hernia can actually occur in both sexes, but is more common in the males. So the weakness in the inguinal region is due to developmental changes within the gonads. Okay, so the gonads in the males are the testes, and in the female are the ovaries. They start way high up in the abdomen, but then they have to move relative to their position. Now, the testes will have to move through the inguinal canal so that it end up within the scrotum in an adult. In the females, the ovaries don't have to move as much. It just have to move down a little bit to the pelvic cavity, okay? But then there is a connection from the ovaries to the labia majora in the female. And therefore, that connection is going to remain as the round ligament in the female. All right. So now there is this process, okay, that is formed by peritoneum that is called a processus vaginalis. This is an outpout formed from peritoneum that will protrude through the various layer of the anterior abdominal wall and acquiring coverings from the layers of the anterior abdominal wall, including the transversalis fascia, then the musculature of the internal oblique, and finally the aponeurosis of the external oblique. You can think of the processus vaginalis as kind of like Lewis and Clark, or you can think of it as a harbinger for the movement of the actual gonad, especially in the male later on. All right. So now let us see how that happens. So at the first part, okay, let's talk about the male in this case. In the female, this testis is going to be the ovary, and the gubernaculum over here, you can think of it as the round ligament. All right. So let's talk about it in the males first. In the males, you have the testis over here, one on each side. Okay. And the testis is going to be connected to the skin of the scrotum down here by a structure that is known as the gubernaculum. All right. So the gubernaculum is going to shorten and shorten and shorten and shorten and allows the testis to move through a tube towards this final end here. And the final end is, of course, the scrotum. Okay. But in the females, something interesting happens. In the females, the ovaries do not move down into the scrotum, just like you probably have noticed, right? But instead, the ovaries, they move down to a cavity, the pelvic cavity that is inside here. So the ovary is going to stay in the pelvic cavity. And as a result, the only thing that is going to pass through the inguinal canal is going to be this gubernaculum here in the female. And in the female, the gubernaculum will eventually turn into the round ligament of the uterus. Okay, it's going to turn into the round ligament of the uterus. But before the gubernaculum can shorten so that the testis can move down into the scrotum, something has to happen first. This layer here, down here, okay, in the deepest layer of the abdomen is called the parietal peritoneum. Okay, now the parietal peritoneum before the movement of the testis, will have to form a tube, okay? This tube right here. This tube here is called the processus vaginalis. And what the processus vaginalis is that it acts like a harbinger of the testis. It will go down here, okay? And in the process of going down here, it's going to push on the layers of the abdomen. Like, for example, you can see that it's pushed on a green layer here, which is the transversalis fascia. It's going to push onto this layer here, or the internal oblique muscle, and it's going to push on the external oblique muscle, and it's going to go through each layer and acquire layers from these parts, okay? It's going to acquire layers from these parts. And the processus vaginalis will continue to go until it reaches the scrotum, at which point it's going to stop. And the movement of the testis will now be able to begin because something else has already cleared the way for it to go down into the scrotum. All right. And then after this whole process is completed, the testis is going to end up into the scrotum. The gubernaculum becomes very, very small vestigial structure. And the processus vaginalis is eventually going to cut off from the main abdomen. Okay. It's going to cut off from here. Okay. But a part of the processus vaginalis is going to stay within. Okay. It's going to stay within this area right here that is very, very close to the testes. And just before we know that, okay, and just because we know that, we are going to be able to identify the layers of the scrotum, which is going to come into very much important, okay, when we talk about a reproductive system of the male and female. All right. Okay, so now let's talk about the inguinal canal. So the inguinal canal is just basically this portion of the tube here, okay, that the testis will have to go through and that the round ligament will have to lead, okay, in order to go down into the scrotum in the male and the labia majora in the female. All right. And these are slit-like passages that they will extend in a downward and medial direction. And so therefore, as you can see, the inguinal canal kind of extend downward like this. You see that? They're going to extend downward and they're going to extend anteriorly, okay? So that it's going to go in an oblique fashion like this, okay? Now, this inguinal canal is going to begin here at the deep inguinal ring, okay? Deep inguinal ring. And then it's going to continue for approximately 4 centimeters and they will end here at the superficial inguinal ring. All right, so the deep inguinal ring is here. The superficial inguinal ring is here, okay? And you can kind of estimate, okay, the location of the deep and the superficial inguinal ring in an actual living person by following these steps. You can see here that this structure is the inguinal ligament, right? And here, at this structure, basically you will have a structure that is called the pubic tubercle. So you can just think of it like this. At the midpoint of the inguinal ligament, okay, a little bit more superior to that would be the deep inguinal ring, okay? A little bit more superior to the midpoint of the inguinal ligament is going to be the deep inguinal ring. Now, the superficial inguinal ring is going to be just a little bit superior to the pubic tubercle. Pubic tubercle is going to be down here. It's going to be a little bit more superior to it. Therefore, it's going to be right here, all right? And similarly, deep inguinal ring is going to be a little bit superior to the midpoint of the inguinal ligament. So it's going to be right here. So that's how you estimate, okay, the location of the structures, the superficial inguinal ring and the deep inguinal ring. Now, the contents of the inguinal canal is going to be different in males versus in female. In males, you will have the genital femoral nerve, the ilioinguinal nerve, through the distal part of the canal only. And the most important structure is going to be the spermatocord, okay? The spermatocord is going to contain the vas deferens, as well as the blood vessel for the vas deferens, okay? As well as some important nerves that is in there. So there's a lot of structure within the spermatocord. And the spermatocord will also contain the arteries and veins that is going to take oxygenated blood to the testicles in the male, as well as taking deoxygenated blood away from the testicles, also in the male. All right. Now, in female, the inguinal canal are much less important because there's only the round ligament of the uterus, as well as the ilioinguinal nerve through distal part of the canal only. Those two are the two structures that traverse the canal in the female. Much less important than in the male, that's for sure. Okay, so now let's talk about the deep inguinal ring. The deep inguinal ring, this one here, okay, is going to begin the inguinal canal, okay? The deep inguinal ring is located at a midpoint, okay, at a point that is midway between the ASIS, or the anterior superior iliac spine over here, and then the pubic symphysis, okay, the pubic symphysis that is just right there, all right, the pubic symphysis that is right here. Or you can think of it as being in the midpoint of the inguinal ligament, and you basically go up a little bit from there and find the deep ring, all right? Now, the deep inguinal ring is going to be immediately lateral to these two vessels, and you call it the inferior epigastric artery over here. The inferior epigastric artery is going to come out from the external iliac artery, okay? And it's going to run more medial to the deep inguinal ring. This is very important, guys. Please keep it in mind, all right? The beginning of the invagination of the transversalis fascia that forms the internal spermatic fascia of the spermatic cord or round ligament. All right. Okay, so now let's talk about the superficial inguinal ring. The superficial inguinal ring is this structure right here that is right above or right superior to the pubic tubercle, okay? And the superficial inguinal ring is formed by a triangular opening in the aponeurosis of the external oblique, okay? External oblique aponeurosis, with the apex pointing superior-laterally and the base formed by the pubic crest, aka this structure that's down here, okay? Now, you will see that at the point where the external oblique connects the pubic portion of the os coxa, there is going to be two parts, okay, of that connection. The inner part right here is called a medial crus, okay? And the lateral part right here is called a medial crus, okay? So the medial and lateral crus kind of make up the sides of the triangle, like this. This is the medial crus, right? And then there's a lateral crus right here, and it makes up the sides of the triangle, okay? And this side of the triangle will allow you to have a slit, and that slit is the superficial inguinal ring. There will also be some fibers that kind of span that slit like this, running in between the two crura. And those fibers are called the intercrural fibers. The intercrural fibers will prevent further widening of the superficial ring. Now, the invagination of the aponeurosis of the external oblique onto the structure traversing the canal will become the external spermatic fascia. We will talk a little bit more when we talk about the structures that traverses the inguinal canal in the male. All right. All right, so now let's talk about the walls of the inguinal canal. So the inguinal canal has an anterior wall, and that anterior wall is this structure right here, okay? This is the anterior wall of the canal, and the anterior wall is formed by the aponeurosis of the external oblique muscle, okay? The external oblique muscle over here. And it's going to be reinforced laterally by the fibers of the internal oblique. So if you look at it way in the lateral side over here, you will see that the internal oblique is going to reinforce the anterior wall a little bit more, okay? So basically, here and here. So the anterior wall is mostly formed from the external oblique aponeurosis, but on the lateral side, you will also see the internal oblique muscle and aponeurosis playing a role in that as well, okay? Now, the internal oblique also contributes a layer called the climastetic fascia to the covering of the structures traversing the inguinal canal. All right? Okay, so now let's talk about the posterior wall. The posterior wall is this green structure right here. That is the posterior wall of the canal. So that green structure right there is the transversalis fascia. But in the 1/3 of the medial part of the inguinal canal, you will also have this structure right here. This structure right here, that is going to help reinforce this canal, okay, on the medial side. And this structure here is a tendon that is the joint it is joined by two structures, okay? The aponeurosis of the internal oblique right here, and the aponeurosis of the transversus abdominis right here. And those two aponeuroses join up to become one tendon, also known as the falx inguinalis, or the conjoint tendon. All right, and the conjoint tendon is going to reinforce the medial 1/3 of the posterior wall of the inguinal canal. The inguinal canal also have a roof and a floor. The roof of the inguinal canal are these arching fibers here. Okay, these two arching fibers here. And those two arching fibers are of the transversus abdominis and the internal oblique muscles. Okay, and the floor of the inguinal canal is going to be made up by that trough that I talked about with you during the muscle, the muscle of the abdominal wall section of our class, when I said that the external oblique aponeurosis go down here and form a trough, right? It's gonna go down here and form a trough right here, all right? Or I said it was a scoop, so it was the same thing, okay? The scoop and the trough. So that scoop basically forms a foundation, okay, for the structures within the inguinal canal to sit on. Okay, so basically the floor of the inguinal canal is basically the medial 1/2 of the inguinal ligament that folds on itself to create a trough on which the contents of the inguinal canal are positioned. Now, on the medial side, you will also have this ligament right here that we have already talked about as well in the muscle lecture, the lacuna ligament. And the lacuna ligament will reinforce most of the medial part of this trough right here. Okay, so that's the floor of the inguinal canal. Now, you will notice something that is very, very interesting. That is like this. Okay, let's go back to this image. As the testes move through this canal and into the scrotum eventually, okay, it's going to take layers from the abdominal wall with it. Okay, so you see, this used to be the external oblique layer, and now it has become a layer. Okay, it has become a layer over here that is going to be a part of the scrotum, right? So if you can imagine it, okay, the scrotum is going to be this structure just down here, okay? The scrotum is going to contain a part of the skin. This will be the skin of the scrotum, as well as a layer of connective tissue that is within that skin, okay? That like that. Now, that layer of connective tissue is called the dartos fascia. So now we have the skin here of the scrotum, and then you have the dartos fascia. All right, and then after that, you will have this layer here. Okay, this layer is stolen. Okay, the testicles, when it's moved through the inguinal canal, is going to steal the layer that is supposedly the external oblique aponeurosis, and it's going to steal the external oblique aponeurosis and drags it down with it, okay? And now down here around the testicles, this is not called the external oblique fascia anymore, but it's going to be called the external spermatic fascia. But it's the same thing, okay? External oblique fascia or external spermatic fascia is from the same source. Okay, and the source is the external oblique aponeurosis up here. All right, so now let us continue with this. With this theme, the muscle and the fascia that is just interior to the external spermatic fascia is called the internal spermatic fascia. Actually, no, not yet. I'm sorry. It's called the cremasteric muscle and fascia. And this cremasteric muscle and fascia, guess what? It comes from this layer here, the internal oblique muscle, okay? And then after that, you will have this layer of green that is inside here. And this one is finally called the internal spermatic fascia. And what it is, okay, it's basically is the continuation of this fascia, that is the transversalis fascia, okay, that is up in the abdominal cavity. Okay, so basically, you have the testicle as it moves through the inguinal canal, it's going to drag layers and layers of other stuff through with it. Okay, so it will become the layers of the scrotum. But we're not done yet, because we are still going to have to examine this layer here. So this layer here, guess what? It is basically this structure here. Let me go back a couple slides. Okay. Remember when we say that the processus vaginalis is going to invaginate into the scrotum area in the male, and then eventually got cut off from the abdominal cavity? Well, guess what? The portion of the processus vaginalis that got cut off becomes a pouch that is going to like, just surround the testicles, okay? And that pouch is what you see here in purple, okay? And you will know that that pouch, okay, is going to be called the tunica vaginalis, okay? And the tunica vaginalis is going to have two layers, a parietal layer of the tunica vaginalis outside, and a visceral layer of the tunica vaginalis that is right on top of the testis. Okay, now inside here, the testes also have a layer, okay, that is coming right on top of the testis. And that layer is eventually going to be called the tunica albuginea. Okay, and it has been there with the testis all along. Okay, the testis has always been covered by tunica albuginea. Sorry about that. And therefore, if you count the layers now, you begin with the skin of the scrotum, okay? That's layer number one. Then you have the dartos fascia that is intrinsic to the scrotum. That's number two. And then as you go in, you get to the layers that was borrowed from the abdominal wall. The external spermatic fascia, which was borrowed from the external oblique aponeurosis up here. Okay, and then you have layer number four, which is the premasteric muscle and fascia, which was borrowed from the internal oblique muscle and fascia up there. And then you have the internal spermatic fascia, which was borrowed from the transversalis fascia up here. All right, and finally, you got the tunica vaginalis, which was borrowed from the peritoneum up here. And finally, you have the tunica albuginea that is intrinsic to the testis. And therefore, from outside to inside, you got 7 layers, okay? 7 layers. And those 7 layers is going to be a characteristic of the scrotum. And therefore, you will see that the scrotum has 7 layers because of that, all right? So it is very important that you guys understand the boundaries of the inguinal canal, including the anterior wall, the posterior wall, the roof, and the floor of the inguinal canal, as well as understanding how each of the layers that eventually covers the testis within the scrotum come to be, okay? Because it is a very, very important part of anatomy. All right, so now let's talk about the contents of the inguinal canal. So the inguinal canal's contents are going to be different regarding on whether you are male or female. If you are a male, you will have the genital femoral nerve and the spermatic cord, as well as the ilioinguinal nerve that is within the inguinal canal, okay? The ilioinguinal nerve is a special case. You will see that the ilioinguinal nerve is this nerve right there, okay? At first, it runs right here in between the internal oblique muscle and the transversus abdominis muscle. But then at a point, when it goes to this location, it's going to get sucked into the canal. And therefore, you will end up with this part here. That is the part of the ilioinguinal nerve. And there is a portion, therefore, of the ilioinguinal nerve that travel within this canal. So basically, the ilioinguinal nerve did not enter here from the beginning like these vessels, but instead it enters the inguinal canal at the midpoint of the inguinal canal and only go through the inguinal canal through the distal part, okay? It wasn't there during the proximal part. And in the female, the contents of the inguinal canal are going to be either the round ligaments of the uterus and the ilioinguinal nerve once again, okay? The reason why you have the round ligament of the uterus inside this canal is simply because of the fact that it is the remnant of the gubernaculum in the female. Remember, the ovaries, they don't go through this canal, okay? In the female, the ovaries don't go through this canal. They go into the pelvic cavity, right up here, okay? But the gubernaculum still exists, and therefore it becomes this round ligament that extends all the way down here. And all the way down here, the female do not have scrotum, okay? But instead, what they have is the labia majora on either side, and therefore this gubernaculum is going to travel within this canal, okay, going to the labia majora in the female and becomes the round ligament of the uterus. All right, very, very important stuff. So now let's talk about the spermatocord. Spermatocord is this structure right here. If you can see it, it's just right there. You see that? That traverses the canal. And as over here suggests, okay, the spermatocord is formed from many different structures, okay, that coalesces and form a very, very big tube right here. Very, very big tube right here. So what are the contents of the spermatocord? The contents of the spermatocord are going to be the vas deferens, aka the tube that transport the semen from the testes all the way, okay, all the way to the seminal vesicles and eventually going through the ejaculatory duct into the urethra, okay? So basically, that's the vas deferens. The vas deferens, you can see of this structure right there, okay, as this structure right there, okay? Besides the vas deferens, you also have the arteries to the vas deferens that is also within this tube, as well as the testicular artery. And the testicular arteries and veins are these structures right here that going down here and become a part, okay, of the spermatocord. And the testicular arteries and veins are just going to go through this inguinal canal within the spermatocord and go to the testes so that they can actually supply the testes with blood. All right. You also have the pampiniform plexus. The pampiniform plexus is basically a plexus of veins that is formed from the testicular veins. So when people say pampiniform plexus, you think testicular veins, okay? And we have already mentioned testicular veins up here, so we will not visit it again. Then you have the cremasteric arteries and veins. They are associated with the cremasteric fascia and muscle, okay? And also the genital branch of the genitofemoral nerve that is also within the spermatocord. In the spermatocord, you also have associated structures like the sympathetic and visceral afferent nerve fibers, the lymphatics, as well as the remnants of the processus vaginalis. Okay, so that's the spermatocord. So as you can see, the spermatocord contains many, many structures, and some of them are functionally important. Okay, the vas deferens is very important. Okay, the artery to vas deferens as well as the testicular artery are important. Pampiniform plexus also important, and all sorts of important nerves like genitofemoral nerve and the sympathetic and visceral afferent nerve. Okay. All right, and now let's talk about some clinical correlate, and we are going to talk about the inguinal hernias. Okay, now what are inguinal hernias? Inguinal hernias are protrusions or passage of a peritoneal sac. And this peritoneal sac can contain abdominal contents or no. Usually, if there is abdominal content within this peritoneal sac, it's going to be loops of bowel, okay? Like, for example, the small intestine. The loops of the small intestine can fit through this peritoneal sac, okay? And it's going to go through, okay? It's going to either go through the inguinal canal from the beginning at the deep inguinal ring, or it can force its way into the inguinal canal without going into the deep inguinal ring first, okay? But whatever it is, okay, it's going to push the contents of the inguinal ring. This peritoneal sac is going to push this content of the inguinal ring until the peritoneal sac will arrive in the male in the scrotum. All right, so you will have, like, you know, a sac, a peritoneal sac that is within your scrotum, and that will be an inguinal hernia. Okay, and there are two types of inguinal hernia. There's a direct type and an indirect type. Okay, the direct type, also called direct inguinal hernias, is a hernia that occurs through the posterior wall of the inguinal canal. Okay, now the indirect inguinal hernia is going to be the herniation of a peritoneal sac through the deep inguinal ring. Okay, so you can remember these two like this. For indirect inguinal hernias, the contents is going to go first into the deep inguinal ring, and then through the inguinal canal, and then going to the superficial inguinal ring into the scrotum. Okay, but when you have a direct inguinal hernia, you don't even need to use the deep inguinal ring. Structure will force its way, okay, into the inguinal canal, and finally passes through the superficial inguinal ring into the scrotum. All right, and just like we said before, inguinal hernias happen in both sexes, not just males, but because in the males there are more structure and bigger structures that passes through the inguinal canal, inguinal hernias tend to happen much more in males than in females. All right. Now, let's just go ahead and see what I mean by direct and indirect inguinal hernia. Let's start with indirect. Okay. The indirect inguinal hernia is the most common type, and of course, it is more common in males. Okay. Now, remember when we talk about this tube right here, right? The processus vaginalis. Okay. The processus vaginalis is going to go down. Okay. It's going to go down here into the scrotum first before the testes can be pulled down to the scrotum. Eventually, this processus vaginalis is going to get cut off, okay, from the abdominal cavity. It got cut off, and the remainder of it is going to become this tunica vaginalis that surrounds the testis. Now, imagine what would happen if the processus vaginalis doesn't get cut off, okay, from the abdominal or the peritoneal cavity. Well, then it's easy. Things like the intestine and peritoneal sacs will be able to herniate its way through this. Okay, like for example, you can see right here, there is a peritoneal sac that herniates through, okay, the inguinal canal in order to get into the scrotum. Okay, and this peritoneal sac can contain loops of bowel or no. It really depends on, like, the situation, but what is important here is for you to realize that in order for this peritoneal sac to get into the scrotum, it has to use the deep inguinal ring first and go through the canal, go through the superficial inguinal ring as well. So indirect inguinal hernia, it will use the deep inguinal ring to get into the scrotum. All right, so the indirect inguinal hernia, deep ring is going to be used. Now, notice here something that is very important. We talked about before that the deep inguinal ring lies more laterally to the inferior epigastric vessels, right? So now, one of the points that we can use to distinguish between an indirect inguinal hernia and a direct inguinal hernia is this. An indirect inguinal hernia always happens lateral, okay, lateral to the inferior epigastric vessels. The direct inguinal hernia, on the other hand, happens medial, okay, happens medial to the inferior epigastric vessels, okay? And so if you ever like concerned about, okay, so if you have a mass that protrudes into this inguinal canal lateral to the inferior epigastric vessels, would it be a direct or indirect one? Indirect inguinal hernia, that is. It will be an indirect inguinal hernia because it's more lateral to these vessels right here. These vessels are more medial. This is more lateral to this vessel, okay? This is something that's very important. So this is an example, okay? And in this example, it's actually quite a severe case in that you have like a significant part of the small intestine going through, okay, the peritoneal sac that leads all the way to the scrotum, okay? This is actually quite a severe case. All right, and now you have direct inguinal hernia. Now, direct inguinal hernia, you don't even use the deep inguinal ring. You don't use this one at all. But you force your way into the inguinal canal. This is the inguinal canal, right? You force your way into the inguinal canal from the posterior part of the anterior abdominal wall. Okay, now, the weakest part of the anterior abdominal wall exists right here in an area that is more medial to the inferior epigastric vessel. And that area is called the inguinal triangle of Hasselbalch. Okay, and the triangle, this triangle, the inguinal triangle Hasselbalch, is formed by laterally by the inferior epigastric artery. So this is the lateral boundary. Medially by this rectus abdominis right here, and inferiorly by the inguinal ligament. And therefore, there will be a triangle in this area where things like, for example, peritoneal sac containing intestines can herniate through if the anterior abdominal wall is weakened. And how is the anterior abdominal wall weakened? Usually, if you have an elderly male, okay, an elderly male who hasn't exercised for a while, his anterior abdominal wall is weak, it is easy for stuff to puncture through this triangle of Hasselbalch, okay, and into the inguinal canal. All right. So now, direct inguinal hernia does not traverse the entire length of the inguinal canal, but only exit via the superficial inguinal ring. Okay. Like I said before, it does not go through the deep inguinal ring. So it forces its way through, maybe to this area here, and traverse only this part of the inguinal ring all the way over here to the superficial inguinal ring. All right. And now we will see that if you look at the abdominal wall, the anterior abdominal wall, all right, from the posterior to anterior, this is what you will see. Okay, these are the inferior epigastric vessels. The red one is the artery, the blue one's the vein. Okay, this is the rectus abdominis muscle. Okay, and this is the lateral border of the rectus abdominis. Over here, you will have the inguinal ligament. Okay, and therefore, the triangle of Hasselbalch is going to be this triangle that is formed by lateral boundary of the rectus abdominis, the inferior epigastric artery, and the inguinal ligament over here. Okay, and this is an area that is the most prone for a direct inguinal hernia. And now you understand why. Now you understand why. If it is an indirect hernia, it will happen lateral. This is lateral, right? Lateral to the inferior epigastric vessels. But if it is a direct inguinal hernia, it is going to happen here, which is medial to the inferior epigastric vessels. Okay, so this is a very important correlate that you have to know. Okay, which one is medial and which one is lateral to the inferior epigastric vessel. Okay, and that is all for this lesson today. Thank you very much once again for listening thus far. I know it has been a difficult lecture, so please go home and review the lecture at your leisure. Okay, my name is Hua once again, and if you need me to answer any question, please comment down on this video or go to me in class and ask the question. Okay, and I will hope that I will see you in the next couple of videos. Bye-bye. Happy studying.